শোনা যাচ্ছে? আওয়াজ আসছে? আছে তো? আজকে যেটা এটা ইন্টারকানেক্টেড ইন্টিগ্রেটেড একটা পার্ট, বইয়ে কোনো একটা জায়গাতে পাবে না, কিছু জিনিস আছে যেগুলো বইতেও পাবে না। সো উইল বি মেকিং আ হোল থিং। খুব রেয়ারলি লং কোশ্চেন এসছে এটা থেকে, কিন্তু শর্ট কোশ্চেন আর এক্সপ্লেন হয় অনেকগুলো আসে। যতদূর আজকে হবে হবে, নেক্সট ডে উইল কন্টিনিউ। এখান থেকে উই উইল ট্রান্সফিউজ ইনটু এফেক্ট অফ সেডেন্টারি লাইফস্টাইল, এটার পরেই যেটা রয়েছে এনএমসি গাইডলাইন্স অনুযায়ী। সো এই দুটো ইন্টিগ্রেটেড পার্টের মধ্যে পড়ছে। এফেক্ট অফ লং টার্ম ফিজিক্যাল ট্রেনিং অন ভেরিয়াস সিস্টেমস, এটা উইল বি স্টার্টিং। তো ফার্স্ট অফ অল কত রকমের এক্সারসাইজ হয় ফার্স্ট সেমিস্টার? আইসোটনিক, আইসোমেট্রিক। এটা যদি আমরা এটা ডিপেন্ড করছে অন দ্য পজিশন অফ দ্য লোড, কতটা মুভ করছে। ইফ দ্য লোড ইজ মুভিং দ্যাট ইজ আইসোটনিক, ইফ দ্য লোড ইজ ইমোবাইল দ্যাট ইজ আইসোমেট্রিক। আইসোটনিকে কি হচ্ছে? দ্য লেংথ ইজ গেটিং চেঞ্জড, মাসল লেংথ ইজ গেটিং চেঞ্জড। টু রিক্যাপিচুলেশন অফ ফার্স্ট সেমিস্টার, লেংথ ইজ গেটিং চেঞ্জড। আইসোমেট্রিকে হচ্ছে মাসল লেংথ ইজ নট চেঞ্জড। আইসোটনিকে দ্য লোড remains constant, isometric the load keeps on changing. Isometric example, if you are pushing the wall, so you can change the amount of resistance you are giving to the wall, so in that way, but your hand or your arm is always at the same length. Isometric is like that. দুটোর মধ্যে কিছু ডিফারেন্স ছিল, we have discussed that, we will again come to that. Isometric, isotonic. What else? What are the other classifications of exercise? One can be aerobic, anaerobic and mixed. তো কিছু গেমস আছে যেগুলো হচ্ছে অ্যারোবিক, কিছু গেমস আছে যেগুলো হচ্ছে অ্যানারোবিক, and some games we have a mixed kind of condition. অ্যারোবিক গেমস কিরকম? ফুটবল আসছে, that is aerobic. anaerobic গেমস কিরকম? যদি কেউ ওয়েট ট্রেনিং, it can be anaerobic. এটাকে মিক্সডেও কনভার্ট করা যায়। and mixed games কিরকম? যেগুলো ইউজুয়ালি বাউটসে খেলা হয় সেগুলো ইউজুয়ালি হচ্ছে মিক্স, লাইক বক্সিং সাপোজ, those are the mixed games. So each game has its own type of requirement and own type of training. Third type, আরেকটা যেটা করা যায় সেটা হচ্ছে classification of exercise এর মধ্যে depending on the time, duration of exercise. So একটা duration হতে পারে long duration of exercise, like suppose if somebody is running for 5000 meter, 10,000 meter or a marathon, it will easily be taking 30 minutes, 1 hour, 2 hours kind of that, depending on the distance. So that is a long duration exercise. Short duration exercise ki sprint. You are running for 100 meters or 200 meters. It is hardly taking 11 seconds, 12 seconds, up to 20 seconds, 24 seconds kind of that. আর এছাড়া আরেকটা হতে পারে, that is interval training, high intensity interval training, that is short burst, repetitive interval and maximum threshold. তিনটে জিনিস রিচ করছে। কিরকম হতে পারে? Maybe somebody is asked to jump to the maximum possible height, maximum number of repetition for a stretch of 30 seconds. তারপরে they are getting a rest. So these are the three ways how we can classify the exercise. So classification of exercise, it can be aerobic, anaerobic, mixed. Classification of exercise can be isotonic, isometric. Classification of exercise on the basis of duration, short duration, long duration, interval. So I will say example of exercise. Individually, each game has its own influence on the type of changes that is happening. একটা জিনিস মাথায় রাখা যে short term changes and long term changes are also different in case of exercise, and occasionally they may in the opposite spectrum also. কিভাবে সেটা we are coming. Short term এ এমন অনেকগুলো চেঞ্জ হয় which are not seen or the opposite reaction is seen in the long term changes. এই জিনিসও আমরা আসছি slowly.
So effect of long-term physical training, first we will be looking at the muscle. So কি চেঞ্জ হয় মাসলসে তোমরাই বলতে পারবে কি চেঞ্জ হয় যদি কেউ লং টার্ম ট্রেনিং এ থাকে? হাইপারট্রফি ইজ দ্য ফার্স্ট থিং। সো হাইপারট্রফিটা কেন হচ্ছে? কজ অফ হাইপারট্রফি মাল্টিপল কজ আছে, যে কোনো একটা। হ্যাঁ, রেজিস্ট্যান্স বাড়ছে। সো মেন কি হচ্ছে? মোটর ইউনিট যে পার্ট গুলো রয়েছে সেগুলো বাড়ছে। সো কন্ট্রাক্টাইল ইউনিট তাদের নাম্বারটা বাড়ছে। সো ফার্স্ট ইজ ইনক্রিজ ইন কন্ট্রাক্টাইল ইউনিট। আর কি হতে পারে মাসলের মধ্যে? সো কয়েকটা পয়েন্ট আছে, জাস্ট লুক এট। আচ্ছা, কালারটা দেখা যাচ্ছে কি হলো? সো যেটা বলেন দ্যাট ইজ কারেক্ট। সো ফার্স্ট ইজ দি মাসল হাইপারট্রফি and that is due to a number of things. কি কারণ? নাম্বার 1, increase number of contractile units. Second, increase phosphocreatine store. Increase amount of glycogen content. Increase capillary density. And definitely better metabolism. So better metabolism. So metabolic profile, it leads to a number of things. So এটাই আসছি, metabolic profile টা improve করছে, improve metabolic profile. Improve metabolic profile. তার মধ্যে কি আসতে পারে? তার মধ্যে আসতে পারে growth factors. Growth factors গুলো কি করছে? Growth factors গুলো capillary density বাড়ায়। What else? More glycogen synthesis. What else? Increase ATP. What else? Increase mitochondria. And আরেকটা আমাদের খুব clumsy হয়ে যাচ্ছে, increase cytochrome oxidase pathway enzymes. So the total, if you look at, এগুলো প্রত্যেকটা আগে তোমাদের পড়ানো হয়ে গেছে। You can, if you wish, you can learn from there. All these things are known. কোনো বইতে এক জায়গায় নেই। Basically, this is a very interconnected area. So this is the whole way how muscles improve after this. What is the difference between hyperplasia and hypertrophy? Hyperplasia, hypertrophy, bolo. Sound আসছে? Hello, check. Hey, sound নেই তো? এগুলো sound নেই, ওই মাইকটা তো। ওই ব্যাটারি নেই। নেগেটিভ এক্সারসাইজ হচ্ছে। এবার এটা দিয়ে between hypertrophy hyperplasia খুব কমন, এগুলো তো বলতে হবে। অন্য কেউ বলো। আজকে মনে হচ্ছে বারাণসীতে এসে গেছি, এত কাশি চারদিকে। হ্যাঁ, সিমস লাইক দ্যাট বেসিক্যালি। সো হোয়াট ইজ দ্য ডিফারেন্স বিটুইন হাইপারপ্লাসিয়া এন্ড হাইপারট্রফি? এদিক থেকে কেউ বলো একই, এগুলো তো বলতে হবে। তো এসে গেল, তো সেকেন্ড সেমিস্টার এসে গেল। ভারতীয় সংবিধানে কোথাও লেখা নেই সেকেন্ড সেমিস্টার আসলে ফার্স্ট সেমিস্টার ভুলে যেতে হবে, কোথাও লেখা নেই। হাইপারপ্লাসিয়াটা কি? তোমাদের তিনটে বেঞ্চ বলো। ও তো ভলেন্টিয়ার নির্বাচন করছে পিছনে ঘুরে, ও বলবে এ বলবে করে আর কি। হাইপারপ্লাসিয়া ইজ দ্য মোর নাম্বার অফ সেলস ও নাম্বার অফ কন্ট্রাক্টাইল ইউনিট যেটা বাড়ছে। বাড়তে পারে এক্সারসাইজে, হাইপারপ্লাসিয়া হতে পারে অ্যাপার্ট ফ্রম হাইপারট্রফি? ডেফিনেটলি হতে পারে। নিউট্রিশন বেটার হলেই হবে। নিউট্রিশন বেটার হলেই hypertrophy is predominant definitely because it is adult, so hyperplasia is always regulated in adults. এটা বাচ্চা হলে তার ক্ষেত্রে হতো। Hypertrophy is definitely predominant, but hyperplasia is also possible, and for that you have to have a better nutrition profile. So muscle এর যদি if you look at the muscle, these are the changes in muscle that happens. নতুন সিস্টেম নাকি? তালা দিয়ে তো ও ভালো। So if this is মাসেল তাহলে চেঞ্জ ক্লিয়ার হয়ে গেছে, সবগুলো লেখা হয়ে গেছে। সো উইল বি মুভিং টু দ্য নেক্সট, দ্যাট ইজ রেসপিরেটরি সিস্টেম। হোয়াট আর দ্য চেঞ্জেস ইন দি রেসপিরেটরি সিস্টেম? সে নিউটনের একটা গল্প ছিল, নিউটন না আইনস্টাইন আমি ভুলে গেছি। উনার বাড়িতে বিড়াল ছিল, তো সেই বিড়ালের জন্য, এগুলো আবার যেতেও পারে, অসুবিধা নেই। তো বিড়াল ছিল, উনি দরজা, একটা বড় বাক্স করেছিলেন যার মধ্যে বিড়াল রাখবেন। উনি একটা দরজা করে দিয়েছিলেন বিড়ালের জন্য, একটা বড় দরজা করেছিলেন, আর তার পাশে একটা ছোট দরজা করেছিলেন। বড়টা বড় বিড়ালের জন্য, ছোটটা ছোট বিড়ালের জন্য। ছোট বিড়ালকে আটকাবার জন্য ছোট দরজাটা উনি সেলোটেপ দিয়ে বন্ধ করে দেন, বড়টা দিয়ে দুজনই ঢুকতে থাকে। সেই রকম ব্যাপার আর কি। তো ব্যাস, ওটাও বাইরে থেকে বন্ধ করে দিচ্ছে। তার মানে এবার যদি মাইক খারাপ হয় আমার আর কোনো অপশন থাকবে না, গেল। সো ইট কামস টু রেসপিরেটরি সিস্টেম। রেসপিরেটরি সিস্টেমে কয়েকটা কনসেপ্ট আমরা we will be recapitulating. First of all, what is maximal breathing capacity? কয়েকটা টার্ম আছে, maximal breathing capacity, what is that? What is VO2? What is VO2 max? তিনটে, এগুলো কে কে বলতে পারবে? হাত তোলো, বলো। ক্রেনিয়াল না পড়তে গিয়ে এগুলো ভুলে গেছো নাকি? ম্যাক্সিমাল ব্রিদিং ক্যাপাসিটি, হোয়াট ডাজ ইট মিন? কি হতে পারে এটা? ওয়ার্ড গুলো থেকে কি মনে হচ্ছে? ম্যাক্সিমাল ব্রিদিং ক্যাপাসিটি কত? এনি আইডিয়া? আচ্ছা, হোয়াট ইজ VO2? এই যাই, এই তো বাজে অবস্থা। হোয়াট ইজ VO2 ম্যাক্স? ম্যাক্সিমাম অক্সিজেন, শুনতে পেলাম লাস্ট ওয়ার্ডটা? না, কনসেন্ট্রেশন নয়। VO2 ম্যাক্স বলছো তো? না, কনসেন্ট্রেশন নয়, ইটস নট কনসেন্ট্রেশন। ইয়েস, ম্যাক্সিমাল ব্রিদিং ক্যাপাসিটি কত কত সেটা? না, ওটা ম্যাক্সিমাল নয়, ওটা অ্যাভারেজ। 6 লিটার এখনই আমাদের রয়েছে। হোয়াট এলস? ম্যাক্সিমাল ব্রিদিং ক্যাপাসিটি হচ্ছে, ওটাকে তোমাকে করতে হবে শুধু 6 লিটার নয়, ওটাকে টাইম দিয়ে গুণ করতে হবে। সো ইটস আ প্রোডাক্ট, 1 মিনিটে কতটা হচ্ছে। So maximal breathing capacity is maximum amount of air that lungs can handle in a 1 minute. Okay? So আমি কিছু বলিনি, এক্সিস্টিং রুল প্রিভেলস, আমার কিছু বলার নেই। যা রুল তাই, মানে দরকার হলো জানলা দিয়ে ঢুকবে, সেটা ওদের ব্যাপার। So maximal breathing capacity, আচ্ছা VO2 জিনিসটা কি? What is VO2? What is VO2 max? যে এগুলো মাথায় ঢুকিয়ে নাও। VO2 is not concentration but the amount of oxygen is extracted. ব্লাড থেকে টিস্যু যতটা অ্যামাউন্ট অফ অক্সিজেন এক্সট্রাক্ট করছে, that is VO2. And VO2 max is the maximal amount of oxygen extracted from blood. দুটোর মধ্যে তাহলে what is required? Try to understand. If you have a higher VO2 max, you will have more oxygen available to your tissue, যেটা বেশি এক্সট্রাক্ট করতে পারছো। সো রিগার্ডিং রেসপিরেটরি সিস্টেম দুটো জিনিস হয়। ব্রিদিং ক্যাপাসিটি during exercise, during acute exercise can increase by 20 times. Breathing capacity during acute exercise can increase by 20 times. VO2, that is extraction of oxygen. Extraction of oxygen. কোথা থেকে extract করছে? It is extracting oxygen from blood. That is VO2. VO2 at rest. If we look at VO2 at rest, VO2 at rest, it is only 250 ml per minute. ml ওটাই পরে আসছে। VO2 at rest হচ্ছে 250 ml per minute. VO2 max in trained athlete it can reach up to 5 liter per minute. কত গুণ হলো? 5 liter by 250, 20 times. So that can increase. 20 times অবধি আমরা ইমপ্রুভ করতে পারি ব্রিদিং ক্যাপাসিটি অ্যান্ড VO2 max কে। ওকে, আনট্রেন্ড পারসন, তার ক্ষেত্রে VO2 max is 3.5 liter per minute. VO2 max in untrained, তার ক্ষেত্রে 3.5 liter per minute. এবারে তাহলে দেখতে পাচ্ছ একটা জিনিস যে there's not much of a difference, 1.5 liter per minute only. তো এইখানে ব্যাপারটা হচ্ছে VO2 max takes years to develop, বাড়ানোর জন্য। So যদি short term exercise, suppose somebody has started his exercise regime and maybe 2 months later we are checking his VO2 max again. So short term exercise that increases VO2 max by 10% only. And by lifelong exercise or very long exercise, we can go only up to 40% higher. 3.5 থেকে 5 কত আর? So এই যে lifelong exercise যেটা VO2 max এত হাই কাদের ক্ষেত্রে? এই যে রিসেন্টলি একজন কেনিয়ান ভদ্রলোক রেগুলার বেসিসে ম্যারাথন গুলো দেখবে সব রেকর্ড ভাঙছে। ম্যারাথন গুলোকে 2 আওয়ার্সে জাস্ট নিচে নামাতে পেরেছে রিসেন্টলি, জাস্ট নিচে। এটা আগে 2 hours 24 minutes এর মতো ছিল। রাইট নাও হি ইজ ডুইং ইট উইদিন 2 hours অলমোস্ট। তো ওনার নামটা আমার মনে পড়ে, এখন অনেক জায়গাতে ছবিটা দিচ্ছে। সো বেসিক্যালি এই ধরনের লোকগুলো যারা দোজ হু আর ম্যারাথনার্স, ইন দ্যাট কেস ইট ক্যান গো আপ টু 5 liter per minute. সো লং টার্ম এক্সারসাইজ ক্যান ইনক্রিজ VO2 max up to that. কি করে VO2 max? হাউ ডু উই মেজার VO2 max? এনি আইডিয়া? স্পোর্টস ল্যাবগুলোতে করা হয়। হাউ ডু উই মেজার? দেখেছো কোনো VO2 max মেজার করা কখনো? Even on any National Geographic or something? না। তোমরা have you heard of Douglas bag? Douglas bag টার্মটা শুনেছো? বলেছিলাম সে বহু আগে হয়ে গেছে, বেরিয়ে গেছে আর কি। কত তারপর ফার্স্ট সেমিস্টার চলে গেল, কত এইসব পরীক্ষা যাচ্ছে উল্টোপাল্টা। সো বেসিক্যালি যেটা হয়, উই ডু ক্যালকুলেট VO2 max. We make an athlete, ভালো স্পোর্টস ল্যাবগুলোতে থাকে, make an athlete to run on treadmill and we keep on increase the grade, ওই অ্যাঙ্গেলটাকে বাড়াতে শুরু করি, and at the same time we keep on increasing the speed. So মোটামুটি 20 kilometer per hour এরকম স্পিড when we do reach, and at a gradient of approximately 25 degree to 30 degree of 20 degree approximately, কারণ ওই ট্রেডমিল গুলো around 20 degree elevation যায়. At that time what we do, we make the athlete breathe in and out through a circuit. তার মানে কি, ওর ফেসে একটা বড় একটা মাস্ক থাকে, and through that circuit he takes on oxygen, and through that circuit only he exhales carbon dioxide. So we measure it from there. এই যে বড় মাস্ক, অনেকগুলো দেখবে ক্রিস্টিয়ানো রোনাল্ডোর অনেকগুলো ছবি বেরোয়, মুখে একটা বড় মাস্ক, দ্যাট ইজ ডগলাস ব্যাগ মডিফাইড ভার্সন। হ্যাঁ, অনেকগুলো জায়গাতে দেখবে যে একটা মুখে ছবি নিয়ে, মুখে একটা মাস্ক নিয়ে দে আর রানিং অন ট্রেডমিল। That is Douglas bag, and that is the instrument to calibrate VO2 max. Clear? So chronic exercise can increase VO2 max by 40%. হয়ে গেল। What else it does to pulmonary system? আর কি কি করতে পারে chronic exercise pulmonary system এ? So a number of things, এগুলো প্রত্যেকটা পয়েন্টস you can elaborate yourself. আগে বলা হয়ে গেছে, জাস্ট এইগুলোকে পরীক্ষার খাতায় only we will want to see these points. তারপরে তো ইলাবোরেশন কি কি রয়েছে। It can increase alveolar recruitment. এগুলো এখন আর বোঝানোর কিছু নেই। Now you should answer, otherwise I will just mention what these are. It will increase alveolar capillary recruitment. Okay, it will improve diffusion capacity. Okay, diffusion capacity একটা ল ছিল, মনে আছে? Fixed law of diffusion. Fixed law of diffusion. If you remember the diffusion capacity, fixed law of diffusion was একটা surface area মানে কি, আমার thickness will come down. The more surface area, the more pressure gradient outside and inside, this will improve the diffusion capacity, and the lesser thickness will improve the diffusion capacity. If you remember the equation, thickness will come at below. তাহলে কি thickness যত কমবে তত diffusion capacity will improve. It is inversely proportional. Now you think, what is alveolar recruitment? নতুন alveoli নয়. What is this? Suppose if we are at rest, a number of alveoli, a significant number of alveoli are constricted. Physiological dead space. They are leading to physiological dead space. And suppose if somebody is having some pneumonia or like that, there's a term called atelectasis. Atelectasis. তাতে কি হয়? Huge number of alveoli, they are already collapsed because of the disease process or inactivity or lack of requirement. Now when somebody starts exercising, and by exercise we are mostly meaning aerobic exercise over here, so more and more requirement of ventilation happens, number one, and therefore more and more requirement of perfusion also occurs because body requires more metabolites. Clear? তাহলে যেহেতু ventilation এর requirement বাড়ছে and perfusion এর requirement বাড়ছে, আর যারা ভুলে গেছো, perfusion is the blood flow to the organ, the blood flow. Ventilation is the air flow to the lungs. So যাদেরই এই জিনিসটা হচ্ছে, in that case what is happening? যখন এইটা হচ্ছে, more number of alveoli are getting stretched, opened. More number of alveoli are getting open. Alveoli চারপাশে কি আছে? Alveolar capillaries. So alveolar capillaries গুলো তখন, the moment alveoli are getting open, capillaries are also getting open. And why capillaries are getting open? Because in pulmonary circuit, oxygen, if tension of oxygen is high, it will lead to vasodilation. Just the opposite of other systemic circulation. So যখনই alveoli are getting open, it is getting more and more oxygen, it is opening up the pulmonary capillaries. So this leads to two things. One is the more recruitment of alveoli, that means more alveoli are coming into the circuit, and more recruitment of alveolo-capillary membrane. Recruitment মানে যেমন সৈন্যদেরকে আমরা recruit করি during some kind of, suppose some unrest or something. Similarly, more number of alveoli and more number of capillaries are coming into function. That is recruitment. If you have these two, definitely your breathing capacity will go high. Third is diffusion capacity. এটা improve করছে. How is it improving? Diffusion capacity? ব্যাপারটা বোঝার চেষ্টা করো. If an alveoli is stretched, যদি alveoliটা stretched হয়, what will happen to the thickness? It will decrease. It will decrease. তাহলে কি হচ্ছে? What will happen to the T in Fick's law of diffusion? It will decrease. Capacity will go up. How do we measure diffusion capacity? What is the term? DLCO. DLCO. সব ভুলে গেছে। সবই কি এগুলো মাথায় রাখতে হবে before exam. You need to connect this way. নইলে কিচ্ছু মাথায় থাকবে না, একদম প্রফে গিয়ে বেসিক্যালি। সো ডিফিউশন ক্যাপাসিটি কিভাবে মেজার করছি? বাই ডিএলসিও। সো অল দিস ক্যান ইমপ্রুভ। এবার একটা এক্সপ্লেন ওয়াই কোশ্চেন, যেটা পরীক্ষায় এসছে বহুবার। সো হোয়াট ডু ইউ থিঙ্ক, whether respiratory system is the limiter of exercise? Is respiratory system the limiter on exercise? Respiratory system limiter নয়। Why respiratory system is not the limiter? CVS limiter. So since we are discussing about respiratory system, so what happens? This is our VO2 max in trend. VO2 max in trend % কত বললাম? That is 5 liter per minute. That is achievable at a maximum breathing capacity of 100 liter per minute. So that means if in a minute you are dealing with 100 liter of air in and out, you can achieve this amount of breathing, this amount of VO2 max, provided the air that you are taking in and out, that is 21% saturated with oxygen. That means the room air. এইটা একটু কমবে if you are running at hills. Otherwise at sea level, air is, and pollution, definitely, that also comes into consideration. So definitely if it is 21% in this room, 21% hopefully, so 21% যদি স্যাচুরেটেড থাকে, 100 liter MBC তেই you will get a VO2 max of 5 liter per minute. What is our actual MBC? Actual MBC, our maximal breathing capacity, that means maximum level till we reach, that is 150 to 170 liter per minute. It means even beyond VO2 max, we can increase our breathing capacity. It means even beyond VO2 max, or we have a reserve. We have a high reserve in respiratory system. তাহলে কি let us discuss what is VO2 max. Maximum amount of oxygen extracted during exercise. Oxygen is supplied by lungs. When maximum amount of oxygen is being extracted, definitely our breathing capacity to be increased. Now breathing capacity at 100 liter per minute, we get VO2 max. But our lungs can reach up to 150 to 170 liter per minute in trained persons. So you can see there is always a reserve of 50 to 70. That means even when you reach your VO2 max, it is still not the end of respiratory system. That means respiratory system is not the limiter to exercise. Somebody else is the limiter, and he rightly said that is cardiovascular. We are coming to that. So respiratory system is not the limiter. Eta ekta question ashe. Next we are moving to effect on cardiovascular system. So long term effect on cardiovascular system, bolo do ekta. Football World Cup asche, maximum players, they have a range of resting heart rate around 50 to 60. Resting heart rate, acha. Tomader mone royeche what is MHR? Maximal heart rate. 220 minus H. Do you have any idea about HRR, heart rate reserve? Na. So this is something. এগুলো এমনি আমাদের as such textbook এ পাবে না, যদি পরীক্ষার খাতায় লিখতে পারো, definitely we will get a better marks. So first of all, what is আমাদের normal heart rate কত? 70 to 80. Range কত? 60 to 100. Approximately 60 to 100. What is our MHR? এটা আগে জানা, আমি বলেওছি, অনেকেই হয়তো বলেছে, অন্য ক্লাসে হয়েছে. It is maximal heart rate. How do we calculate it? It is calculated by 220 minus age in years. So if you are 20 years of age, your maximal heart rate can go up to 200 per minute. This is sinus. Dhoro 20 years of age and suddenly you are feeling a little bit of palpitation and your heart rate is 250. Is this possible? Clinical question. You are 20 years of age. All of a sudden you are having some palpitation. Tomar monitor lagano holo. And in the monitor it is showing that your heart rate is 250. Is this possible? So is it sinus? তাহলে এটা কি হতে পারে? So these are tachyarrhythmia. এটা খুব ইম্পর্টেন্ট একটা কনসেপ্ট. তুমি যখনই suppose in ICU, if you are seeing a patient who is aged 70 years and he is having 180 beats per minute, that is above, beyond his MHR. So definitely that is not sinus rhythm. Some other tachyarrhythmia is running. It can be AF, it can be PSVT, that means supraventricular tachycardia. It can also be flutter, it can also be ventricular tachycardia, whatever. Ventricular flutter, ventricular tachycardia, whatever it is, but it is not sinus. Your sinus rhythm can only go up to MHR. Okay? Then we are coming to third concept, that is RHR, which is resting heart rate. Resting heart rate. So resting heart rate কত? এই মোমেন্টে তোমাদের যদি পালস দেখা হয় যেটা, সেটা হচ্ছে resting heart rate. Everybody is having some resting heart rate. কারো ক্ষেত্রে 70, কারো ক্ষেত্রে 80. If somebody is very anxious, এটা 90, 100, at that level also it can reach. What is heart rate reserve? Heart rate reserve. এটা কি? Any idea? এটা ভীষণ ইউজ হয় স্পোর্টস মেডিসিনে, হার্ট রেট রিজার্ভটা, টু সি দ্য ট্রেনিং ইন্টেন্সিটি অ্যান্ড ট্রেনিং রেগুলারিটি. হোয়াট ইজ দ্যাট? হার্ট রেট রিজার্ভ হচ্ছে MHR মাইনাস RHR, ম্যাক্সিমাল হার্ট রেট মাইনাস রেস্টিং হার্ট রেট, ম্যাক্সিমাল হার্ট রেট মাইনাস রেস্টিং হার্ট রেট. এবার জাস্ট একটা just do a calculation, simple calculation. You are 20 years, your maximal heart rate is 200. Right now your resting heart rate is 70. So your heart rate reserve is 130. What does that mean? If you are doing exercise, you can go up to 200. So you have this 130 span to reach. So up to 100% of amateur only we can exercise. After that we can't exercise. Okay. So tomar 130. Tell me one thing. If heart rate reserve is low, what does that signify? Heart rate reserve is low. Suppose karo heart rate reserve 100 and suppose karo heart rate reserve 160. So who is having more exercise capacity? Jar 160 ache. So how can we improve the heart rate reserve? We can't improve the heart rate reserve by increasing the amateur because we don't have control on amateur. Calendar gulo change hobe, amader boyesh barbe, amateur will be fixed. Tale resting heart rate, if you can reduce resting heart rate, we can improve the heart rate reserve and thereby improve our capacity to do exercise. Ki kore resting heart rate ta improve korano jay? Now it comes to that. So how we can improve the resting heart rate? Ki hote pare? So we need to reduce the resting heart rate, simple thing. So that can be done through a number of pathways. Ki pathway ache? First, improve parasympathetic tone. Jodi parasympathetic tone better hoy, resting heart rate will come down. And that comes through regular exercise. Second, decreasing the sympathetic tone. Third, decreasing the cortisol response. Fourth, improving the size of the heart, athletic bradycardia and athletic cardiomegaly. So these are 4 ways by which we can improve the heart rate reserve. Kiki? Increase parasympathetic tone, decrease sympathetic tone, decrease cortisol response, and increase the size of heart. These are the 4 areas by which it can be done. How we can achieve it? Regular practice. So regular practice. It's ekdom simple. Keu jodi prothom din, first day if you are doing some exercise, sympathetic tone will be much higher because body will take it as a fight or flight. The more you do the same thing, body will get adapted, sympathetic stimulation will come down, your parasympathetic stimulation will go up. Similarly, cortisol also, if you do exercise, some tough exercise for the first time, or if you are doing exercise beyond 45 minutes to 60 minutes, hypercortisolemia happens. So cortisol gets high. Joto cortisol high hobe, definitely your resting heart rate will go up. How we can improve it? The more you exercise, the longer you exercise, there will be remodeling in left ventricle, leading to thicker left ventricle, leading to cardiomegaly, and that leads to decreased heart rate. Athletic bradycardia jeta hoy, what are the reasons for athletic bradycardia? Jodi bole 5-3 পাওয়ার জন্য সবাই লিখতে পারবে, এটাকে যদি if you have to improve athletic bradycardia from multiple area, you need to act on it. কি হতে পারে? What are the reasons of athletic bradycardia? এক হচ্ছে there is cardiomegaly. Size of left ventricle has increased. As size of left ventricle has increased, your stroke volume will increase. কারণ কি left ventricle size বাড়লে the myocardial thickness is also increased. That means contractility of heart is increased, so stroke volume is also increased. So if you remember, cardiac output was stroke volume into heart rate. So for a equal cardiac output, if it goes high, we can go like that. It can go down. Heart rate can go down. This is one. Second, if your VO2 max increases. Second is long-term training that helps in increasing VO2 max. How that is possible? That is possible by increased recruitment, increased mitochondria, increased glycogen. So all leading to better extraction. So if you can extract more oxygen, that means you require less blood to be pumped. Alpo blood theke jodi required oxygen, if you can take it, tale less blood to be pumped. If less blood to be pumped, less cardiac output is required. So you will be more efficient handler of cardiac output. The longer you exercise, you will become a more efficient handler of cardiac output. So definitely you will require less cardiac output, so less heart rate. Clear? Long term e gele ei jinish gulo changes gulo asche. So next, what is the effect on blood pressure? সো আইসোটনিক হলে কি হবে, আইসোমেট্রিক হলে কি হবে? Okay, so if we are getting isotonic, that is leading to three things. Stroke volume will increase, contractility will increase, cardiac output will increase. So all three lead to increase SBP. But in isotonic, there is increase local metabolites, increased secretion of local metabolites, which is transfused through the whole body. And local metabolites যদি generate করে, and if that local metabolites is generated, কারণ কি ধরো isotonic যখন করছি, we are flexing and extending. So the moment we are extending, that will move into the bloodstream, local metabolites. So the moment local metabolites are moving into bloodstream, and who are all these local metabolites? This can be lactate, this can be adenosine, this can be phosphate, this can be H+, this can be potassium, all these, substance P, everything is the local metabolite. Histamine, all of them are local metabolites. And what they do? The more local metabolites flows through the circulation, there will be more vasodilation. And the more vasodilation happens, and more in skeletal muscle actually, so it will lead to reduction in total peripheral resistance, leading to decrease in diastolic blood pressure. So isotonic exercise, since there is movement, there is dispersion of local metabolites who are vasodilatory in nature, all through the body and mainly through the muscle, it causes vasodilation. Difference with isometric, the muscle capillaries are always in contracted state in isometric. কারণ কি তুমি ঠেলছো, continuously sustained contraction. So local metabolites will still be generated over there. But the problem is they will not be metabolized to the next level, they will be accumulated and they will stay over there. Peripheral resistance বাড়ছে দুটো কারণে, একটা হচ্ছে local metabolites, they are stayed over there, they only have action over there, they are not going through all through the body. Second, you are contracting your muscle, so all the vessels passing through the muscle are under constant tone. So therefore peripheral resistance is high, there is no release of peripheral resistance in isometric exercise. এই পার্টটা, SBP part will remain the same, DBP part will also go high. So isometric এ যেটা হয়, we have high SBP, high DBP, আর isotonic এ যেটা হয়, high SBP, low DBP. কিন্তু this equation is only for fast prof. Actually it is not that simple. কারণ কি এরপরে cortisol response আসছে, hypothalamus pituitary adrenal axis is also coming into the picture, ANP, BNP, they are also coming into the picture, pressure natrius is coming into the picture, so this will become very complex. Insulin resistance is also coming into the picture, adiposity is also coming into the picture. তোমার বডি, সো এগুলো প্রচন্ড কমপ্লেক্স দাঁড়িয়ে যায়। তোমাদের ফার্স্ট প্রপের এক্সপ্লেন ওয়াই কোশ্চেনের জন্য দিস ইজ সাফিসিয়েন্ট, এইটুকু লিখলেই যথেষ্ট। এটা পরবর্তীকালে রিসার্চ ওরিয়েন্টেড ওয়েতে এটা অনেকটা বেশি কমপ্লেক্স দাঁড়ায়। আরেকটা নতুন জিনিস বলবো যেটা মোস্ট লাইকলি কেউই কখনো পড়োনি, সো এটা পড়েছো, রিকভারি। যেই মোমেন্টে আমরা ধরো এক্সারসাইজ করছি তারপর তো রিকভারি হয়। সো হাউ ডু উই ক্যালকুলেট রিকভারি and what are happening at recovery? And the other thing is fatigue. এটাও তোমরা পড়েছো, but we will give some new information. এগুলো তোমাদের বইগুলোতে পাবে না। So we will be discussing about fatigue and recovery right now. আচ্ছা, O2 ডেপটাও একটা ইম্পর্টেন্ট পার্ট, সেটা তোমাদের এখন আর আমি রেসপিরেটরিতে ছিল, সেটা তো বারবার বলা হয়েছে, বেসিক্যালি উই আর নট কামিং ইনটু দ্যাট। সো রিকভারি অ্যান্ড ফ্যাটিগ। So first of all, আমাকে need to understand what fatigue is. What do you mean by fatigue? What do you mean by recovery? Fatigue কি? এই যে ক্লাসটা 40 মিনিট ধরে শুনতে শুনতে যে বোরডমটা আসছে, দ্যাট ইজ ফ্যাটিগ। যে মোমেন্টে 10টা বাজবে দেন উই উইল বি রিকভার্ড। ঠিক আছে? হ্যাঁ, যারা একদম বেরিয়ে যাবে শান্তিনিকেতন এক্সপ্রেস ধরে তারা ফুললি রিকভার্ড and released and relieved. So that is the pathway total. So fatigue জিনিসটা কি, how fatigue comes in, sets in? ল্যাকটেট তো একটা গেল, তো ফ্যাটিক দুটো হয়, সেন্ট্রাল, পেরিফেরাল। ইটস ভেরি কমপ্লেক্স, একটু নতুন জিনিস বলছি, এগুলো ডাইরেক্টলি বইতে পাবে না। সো সেন্ট্রাল ফ্যাটিক এটা কেন হচ্ছে? সিএনএস এ কি হচ্ছে, কি কোন নিউরোট্রান্সমিটার ফল ডাউন করছে? ডোপামিন, কারেক্ট, ডোপামিন। ঠিক আছে, দুটো নিউরোট্রান্সমিটারের জন্য ইউজুয়ালি ফ্যাটিগ আসে। ওয়ান ইজ ডোপামিন কামিং ডাউন and the second is cannabinoids coming down. Cannabinoids মানে cannabis like substances আমাদের ডিনোভো রয়েছে বডিতে। So cannabinoids এগুলো ডিনোভো রয়েছে। endorphin is one of them, encephalin is one of them, dynorphin is one of them, এগুলো অনেকগুলো, এগুলোর নামও চেঞ্জ হতে শুরু করে বেসিক্যালি। So cannabinoids falling down, this two. The other molecule that is serotonin, এটাও একটা ইম্পর্টেন্ট জোন। So if we look at the chemistry of motivation, these are the chemistry of motivation. So if you have higher range of these, you will be having a higher motivation, and definitely if you have lower or these are down, motivation will come down. Now motivation is connected with a multiple pathway. কি থাকছে? লিম্বিক কর্টেক্স is playing a role over there, amygdala is playing a role over there, hippocampus playing a role over there, hypothalamus playing a role over there, and primary motor and sensory cortex both are playing a role over there. পুরো জিনিসটা হচ্ছে। তাহলে কি এটা থেকে বোঝা যায় যে suppose somebody is training very hard, there are multiple aspect of training which he is imbibing via his CNS. কি হতে পারে ট্রেনিং এ? There can be pain, and pain is transmitted to the sensory cortex. This is fed up to the limbic cortex. Now if you have a greater goal, you will try to push yourself. কোনটা? স্ট্রেসে আসছি, স্ট্রেসেও আসছি। If you have a greater goal, so definitely you will try to push yourself. যাদের এই greater goal or particular purpose এ ব্যাপারটা বাধা থাকে, they have a higher level of dopamine that will overcome this particular perception. That is one. This is known as central fatigue. So if you have higher motivation, you have lesser start of central fatigue. Coming to the peripheral fatigue, সেটা হচ্ছে due to the lactate. Peripheral fatigue কেন হচ্ছে? Due to lactate. So peripheral fatigue এ দুটো জিনিস আছে। One is decrease in ATP store, increase in lactate or blood lactate, decrease in phosphocreatine, obviously these are linked, phosphocreatine, and decrease in glycogen content. Occasionally hypoglycemia যদি সেরকম লেভেলটায় যায়, or if you are starving and exercising simultaneously, that can set in. Occasionally dehydration and electrolyte imbalance যদি সেরকম লেভেলে if you go through. So all these can cause peripheral fatigue. এখানে একটা যদি কোশ্চেন কঠিন হয়, there can be one short note যেটা most likely বইগুলোতে নেই, that is lactate threshold. What is lactate threshold? কেউ জানে? lactate thresholdটা এটা যদি কোশ্চেন কঠিন হয়, and this is important candidate for your MCQ. So what is lactate threshold? Whenever we are doing submaximal exercise, exercise করলেই তো lactate তৈরি হচ্ছে। Whenever we are doing submaximal exercise, the rate of production of lactate and rate of utilization of lactate are maintained in a homeostasis. So যদি এক্সারসাইজটা ম্যাক্সিমাম লিমিটের থেকে কম করো, in that case x amount of lactate will be created, y amount of lactate will be dissipated, and x is less than y. So at this time there is no fatigue. Lactate threshold is that point and beyond when rate of production is higher then rate of excretion and metabolization of lactate, that is the lactate threshold. এটা কিন্তু টেস্ট করা হয়। তোমরা জানি না জানো কিনা, ইন ক্লিনিক্যাল স্পোর্টস ল্যাবরেটরি যেগুলো রয়েছে প্রত্যেকটাতে, যেমন হ্যাভ ইউ সিন দ্য অ্যাকিউচেক গ্লুকোমিটার? হ্যাঁ, আঙ্গুল ফুটিয়ে জাস্ট একটা স্ট্রিপে ল্যাকটেট স্ট্রিপ ইজ অলসো অ্যাভেলেবল। সো একটা প্লেয়ার যখন দৌড়াচ্ছে ট্রেডমিলে, যখন দেখা হয় অ্যানারোবিক থ্রেশোল্ডটা, ল্যাকটেট দিয়ে কি দেখি? অ্যানারোবিক থ্রেশোল্ড। ভীষণভাবে এই হকি প্লেয়ার, ফুটবল প্লেয়ার এদেরকে রেগুলার বেসিসে করা হয় আর কি, যে কোনো প্রপার স্পোর্টস সায়েন্টিফিক ল্যাবগুলোতে। সো হোয়াট ইজ ডান, ওদেরকে ট্রেডমিলে দৌড় করানো হয়, বিফোর ইউ স্টার্ট একটা ল্যাকটেট দেখে নেওয়া হয়, একটা ল্যাকটেট দেখে নেওয়া হয়। তারপরে যখন ওরা ফ্যাটিগ রিচ করছে আর তারপরে চলতে পারছে না, করতে পারছে না, অ্যাট দ্যাট টাইম এগেইন উই চেক দ্য ল্যাকটেট, দেয়ার ইজ আ গ্যাপ, ল্যাকটেট হ্যাজ ইনক্রিজড, ব্লাড ল্যাকটেট, ক্যাপিলারি ল্যাকটেট হ্যাজ ইনক্রিজড। এইবারে দেখা হয় ও কতটা লোড, ফর হাউ মেনি মিনিটস হি কুড সাস্টেন বিফোর হি রিচেস দি ল্যাকটেট থ্রেশোল্ড, অ্যান্ড অল দিস থিংস আর পুট ইন আ লগ। এই যে থিওরিটিক্যাল কোচিং যেখানে হয় প্রত্যেকটা ভালো স্পোর্টস ল্যাবে, দিস থিংস আর দেয়ার। সো ল্যাকটেট থ্রেশোল্ড দেখে, অ্যান্ড লং টার্ম ট্রেনিং, you know, it pushes the lactate threshold further beyond. তাহলে কি হচ্ছে, আগে suppose somebody who is untrained or mediocrely trained, he was reaching his lactate threshold around 15 minutes of running. Now as he is training more and more and more, it is becoming 19 minutes, 22 minutes, kind of that, and that is the progress which is regularly monitored. Clear everybody? So lactate threshold যদি কোশ্চেন আসে, this will be the answer. Chances are less, হ্যাঁ, কিন্তু পরবর্তীকালে তোমাদের নেক্সট যদি দিতে হয় এই জাতীয় কোশ্চেনগুলো আসবে, বিকজ দিজ আর ক্লিনিক্যাল পার্ট, দিজ আর অ্যাকচুয়াল পার্ট যেগুলো ডে টু ডে করা হয়, যেখানে ফ্যাসিলিটিস আছে। দিস ইজ ল্যাকটেট থ্রেশোল্ড। ওকে, সো নাও উই আর মুভিং টু দিস ইজ দ্য ফ্যাটিগ। হোয়াট ইজ রিকভারি? What is recovery? No, simple thing. Recovery is now you are able to come back and restart the exercise. যে এক্সারসাইজের জন্য all the things which was gone, now things are replenished. Recovery মানে কি? আজকে কেউ একটা 1 hour সেশন করলো, after 1 hour session he is totally fatigued, now he is taking some rest, he is taking nutrition, throughout the day things are being recovered, muscle glycogen content is being recovered, initially oxygen debt is already paid, your blood flow is recovered, lactate is completely gone. So different parts of recovery, and definitely if there is any wear and tear, that is also completely gone. এবারে চলে আসছি অ্যাপ্লাইড ফিজিওলজিতে, হাউ ডু উই চেক রিকভারি, কিভাবে আমরা রিকভারি দেখতে পারি। এটাও কিন্তু নিট লেভেলে কোশ্চেন আসতে পারে, এটা করা হয়ে থাকে রেগুলার, বাট তোমাদের বইগুলোতে নেই। সো আই উইল বি টেলিং। সো রিকভারি কি করে বুঝবো, দুটো জিনিস দিয়ে আজকে শেষ করবো। ফ্রম হিয়ার উই উইল বি স্টার্টিং ফ্রম দ্য নেক্সট অন দ্য নেক্সট ডে। কি দেখা হয়, এনিবডি হ্যাভিং এনি আইডিয়া রিকভারি কিভাবে দেখা হয়? ব্লাড এন্ড ইউরিন টেস্ট। ওকে, ইউ আর কারেক্ট। কি দেখা হয় ব্লাড এন্ড ইউরিনে? ক্রিয়েটিনিন। আচ্ছা, ব্লাডে ল্যাকটেট যে দেখা হয় না তা না, ল্যাকটেট দেখা যেতে পারে, বাট ক্রিয়েটিনিনটা না, ক্রিয়েটিনিন ইজ নট দ্যাট কাইন্ড অফ আ পালস থিং, এন্ড ক্রিয়েটিনিন বাড়তে পারে ইন ভেরি সিভিয়ার এক্সারসাইজ ইউরিনে, বাট ইন মাইল্ড টু মডারেট এক্সারসাইজ ক্রিয়েটিনিন বাড়বে না। ক্রিয়েটিনিন ডাজন্ট হ্যাভ দ্যাট সাইন ওয়েভ প্যাটার্ন, যতটা প্যাটার্ন আমি যে কেমিক্যালটা এক্ষুনি বলবো যেটার আছে। ট্যাকিপনিয়া তো কমে যাচ্ছে, বাট জাস্ট তুমি একটা জিনিস কল্পনা করো, ইউ হ্যাভ ডান আ ভেরি সিভিয়ার এক্সারসাইজ ফর 1 hour, আফটার 10 minutes ইউর ট্যাকিপনিয়া উইল বি গন, বাট আর ইউ রিকভার্ড? তুমি কি আবার ওই সেশনটা করতে পারবে? নো, ইউ নিড আ ডে অর 2 ডিপেন্ডিং অন ট্রেনিং সেশন। নাহলে তো দিনে 10 বার করে লোকে ট্রেন করতো। ইভেন প্রফেশনাল অ্যাথলিটস দে ট্রেন ফর 4 hours to 6 hours, not the same intensity, different things, and not all are related to their specific sports discipline. ডিফারেন্ট জিনিসগুলো তারা করে থাকে, ঠিক আছে? সেটাও ডিফারেন্ট, মানে সকালে বিকেলে কখনো দুপুরেও ঢোকালো এরকম ব্যাপার, বাট নট মোর দ্যান দ্যাট। 4 hours ইজ সাফিসিয়েন্ট মোস্ট অফ দ্য টাইম। সো রিকভারিটা আমরা বুঝি একটা পার্টিকুলার রেশিও দিয়ে, একটা পার্টিকুলার রেশিও আছে, অ্যান্ড দ্যাট রেশিও ইজ, এটা দেখে নাও, T:C, টেস্টোস্টেরন ইজ টু কর্টিসল, টেস্টোস্টেরন ইজ টু কর্টিসল রেশিও। তুমি যেটা বললে ইউরিন ইজ কারেক্ট, বাট ইউরিনে কর্টিসল দেখা হয়, রিকভারির জন্য। সো blood testosterone is to cortisol. So what is the basic difference between testosterone and cortisol? কি টাইপের হরমোন এরা? Testosterone is anabolic, cortisol is catabolic. Testosterone is anabolic, cortisol is catabolic. So the moment testosterone cortisol ratio is more than 1, that means body is again in anabolic phase, and that signifies recovery. So testosterone cortisol ratio দিয়ে অনেকগুলো জিনিস দেখা হয়, লিখে নিতে পারো। physiological stress, it's a biomarker for physiological stress, biomarker for psychological stress also, testosterone cortisol. স্টাডি আছে, কয়েকটা দেশে স্টাডি হয়েছে যাদের ক্ষেত্রে টেস্টোস্টেরন কর্টিসল, এটা একটু অন্যদিকে চলে যাচ্ছে, টেস্টোস্টেরন কর্টিসল রেশিও মোর ইন মেলস যদি থাকে, দেয়ার ইজ হায়ার চান্স অফ ডোমেস্টিক ভায়োলেন্স ক্রিয়েটেড বাই দেম। দিস ক্যান অলসো হ্যাপেন, এটা নিয়েও স্টাডি হয়েছে। হ্যাঁ, সো বাট দ্যাটস আ ডিফারেন্ট থিং, আমাদের এটার সঙ্গে কানেক্টেড নয়। সো টেস্টোস্টেরন কর্টিসল রেশিও, the moment it is more than 1, you are in the recovery phase, your recovery is complete, body is now in anabolic zone. তার আগে অবধি কর্টিসল যদি বেশি থাকে, you are not in anabolic zone. And biomarker of overtraining, biomarker of overtraining, ইন্ডিয়ান পুরো স্পোর্টসের সিস্টেমটাতে এগুলো আসার পরে there has been a lot of change. ওভারট্রেনিংটা মারাত্মক হতো। হ্যাঁ, ওভারট্রেনিং থাকলে অ্যাকচুয়ালি you will lose mass and you will not grow, and your proprioception will come down, your neuromodulation will come down, all of this. আজকে এখানেই রাখি, we'll be starting, next day will be long term effect on psychology, mood, endocrine, এই পার্টগুলো বাকি রইলো, we'll be doing next day onwards.
So good morning everyone. So we have a little bit issues with the mics today, but anyways, we are not a great deal of content we are not going to cover today. So we are going to see this base of the skull, and rather we have seen that, and from there we are going to talk about the base. Oh, sorry. This is the base of the skull. Wherever we have talked about, into this particular base of the skull. So from the base of the skull, we have moving to this particular uncontained, we call them as base of the brain, which is theoretical content and as well as practical content we are going to discuss today. And there are few areas in this particular today's content can be given as an exam short notes in these areas. So which we are going to talk and discuss today, and we are going to discuss how we are going to write that if this thing surfaces as an exam question. Now, unlike this particular surface views which you already have covered through, which are like a lateral surface or superlateral surface of this brain or medial surface of the brain, this is one of the areas where we are going to see, which is under surface of the brain, which is also known as inferior surface of the brain, as well as the base of the brain. Now this particular views, whenever you're going to see, we already have seen these areas yesterday, and we are going to reflect more in a practical session for the day, is this base of the brain. Now you're seeing this particular base of the brain from the under surface, and you're looking at this. So whenever you are looking at this content, we are going to see three of these parts of this neurostructure. One is that the brain cerebrum itself, the other is the cerebellum, which is the hind brain, and communicating with these brain parts, hind brain and this particular forebrain, we have a brainstem which is communicating with the spinal cord, which is the other part. So whenever we are seeing this content, you are going to see the undersurface of the brain, undersurface of the cerebellum, and the anterior surface of the brainstem. And we all know the brainstem have got three different components, Above downwards, we call them as midbrain. Then we have the medulla, and then we have these midbrain, pons, and medulla. There's a three sequel contained above down, which is continued down as a spinal cord when it is exiting through these skull foramens or the skull content or skull cavity. Now today's idea is that we are going to see what are the things we are going to see first thing, and once you are looking at it, what are the things or what are the brain surface you are seeing, and what are the nerves that you are going to look into it. So we are just like discuss the similar content as we call them as the base of the skull, where we learn the foraminas. Through the foraminas there are nerves exiting through it. Now those nerves which are exiting is basically coming from the brain or the brainstem. So they have an attachment on the brainstem and they are exiting through the foraminas. When you remove the brain, like the way we have taken it out, it has some ripped part of the cranial nerves. So whenever you are having this particular brain removed, a part of this neural tissue, which is the nerve, which is with the brain substance, and a part of things sticks to this particular foraminas through which they are exiting. So this particular thing can be tested in two different ways. Attachments of the cranial nerve into this particular brainstem inferior surface or this particular inferior view or the base of the brain, and the same thing, the cranial nerve when it is exiting through these foraminas in the skull, in the dry bone, that can be tested likewise. So we have to know where from they are coming in the brain region or the brainstem and how they are exiting through the foraminas, and the exam will be following subsequently. Now, so whenever you are seeing this, the basal view of the brain, we are going to see these contents. So we are going to see the cerebrum, and in the cerebrum, the surface we are going to see, we call them as orbital surface and as well as tentorial surface, which is sitting on the top of the tentorium cerebelli. So this surface of the brain, we call them as orbital surface or tentorial surface. Next to that, we are going to lodge into a space, we call them as interpedunculaire fossa. This interpedunculaire fossa itself, we have a boundary, it has a content to it. It itself could be given as an exam short note. It is a very precise exam short note, and the content and the clinical anatomy related to it could be surfacing. Second thing, over here, next to this, we have this chiasm. So optic nerve crisscrossing in this particular point, we call them as optic chiasm, which is some fiber is taking cross and some fiber is not, and making this particular region which is close to the hypophysis cerebri, which is known as this pituitary gland, which has a close relationship to it. So that part as well is a content. Then we have this neural tissue to it, we have this vascular content, we call them a circulus villus, which is one of the highest yield area of the blood circulation of the brain is concerned. We see many a times the circle of Willis is surfacing as an exam question, and we have to prepare that likewise. Other thing, we have to see this particular cerebellum along with the brainstem, the anterior surface of the pons and the medulla, these things are there. As we are discussing this particular brain tissues, I am not just like dig deep into this particular cerebellum and the brainstem, because they have a separate session, separate class for it. We are not going to talk detail about it. Now next to that, we are going to see this content, which is having a very important thing about the nerve attachments in this brainstem or these different neural tissues. We call them as superficial attachments of the cranial nerve. And this is one of the areas where you have to be paying attention whenever you are going through. Now let's roll through this, the contents, whatever you're seeing. We call them as the surface of the brain. We call them as inferior surface of the brain, which is split into two surfaces. Anteriorly, we call them as orbital surface. Posteriorly, we call them as tentorium surface. Split it together or split it by this particular area, we call them as lateral sulcus. So the stem of the lateral sulcus splitting this particular area, which is inferior surface of the brain, into two halves. This area which you're seeing anteriorly, we call them as orbital surface. On this back side, this surface, we call them as tentorial surface. Now talking about this particular orbital surface. So here we have a sulcus which is existing over here. So into this particular sulcus, we see this, the olfactory nerve is sitting on it. And it is colored over here with a green, like here on this particular picture. So this surface, which is colored over here, we call them as gyri. And this gyri is straight. We call them as rectus We call this as this particular gyrus as gyrus rectus, straight gyrus, which is present over here, which is lying medial to this olfactory bulb. So the olfactory bulb is present in here, and this particular gyri you are referring it here, comparing with this particular picture like here. So this is the same area is colored over here with this yellow shadow over here. So this particular orbital surface can be divided off two spaces. One is this yellow shadow, whatever you're seeing here, and the green shadow which is present on this region. So this region we call them as gyri recti, and the rest of this particular region we call them as orbital surface. Now this orbital surface is again split into anterior, posterior, medial and lateral segments by this H-shaped sulcus which is present in here. As you can trace here, one limb, another limb like this, and splitting into it. So this region we call them as orbital surface, and this region we call them as gyrus recti. So these are the two spaces which you are seeing here in this undersurface placed on the anterior surface to the stem of the lateral sulcus. Moving back on the posterior side, we have another surface. We call them as tentorial surface. So this picture on the right side is reflecting this tentorial surface which you are seeing on the back side. You have another picture about this tentorial surface, which is this pink shadow which you are seeing here in the back side. So this surface we call them as tentorial surface. Now in this region we have two cleft which is present in here, which is need to be identified, which is one sulcus which is present on the midline or close to midline. This is one, and then we have this particular occipitotemporal sulcus. This is another one, another one. These two sulcus are there. So this is one sulcus which is present in the midline or close to the midline. We call them as collateral sulcus. And next to it, we have another sulcus. We call them as occipitotemporal sulcus. Now these two sulcus splits this particular area into 1, 2 and 3 domains. So this medial domain, then intermediate and the lateral domain. So this tentorial surface is split into 3 halves. Now we take this particular medial area or this medial gyri at the point. So this medial gyri from the back to front we have 3 areas. From back side, this region which is on the posterior side, we call this area as lingual gyrus. Next to the lingual gyrus we call them as parahippocampal gyrus. Now this from this parahippocampal gyrus which is moving to the anterior surface which is bulged over here, we call them as uncus. So these are the 3 domains present in the midline medial to this collateral sulcus. Lingual gyrus, parahippocampal gyrus, and the bulge over here medially we call them as uncus. So they are colored in this particular picture with these different colors. So slide is not this battery is also is not working anyways. So these are the things about this particular parahippocampal gyrus, lingual gyrus and the uncus. Yes, that's it. So you see that different colors are used over here on these regions. So the posterior side you cannot see, which is a lingual gyrus, then it's continued down as a parahippocampal gyrus in the front side, which is the red shadow, and the uncus, which is the medial one as you are seeing there. So these are the 3 areas close to the midline which you have this particular next to it. Now other than then we have this particular space which is lying between this collateral sulcus and this particular area which is known as the occipitotemporal region. So one is present in the medial to it, one is present lateral to it. So these particular areas which is present on the lateral side and the medial side, we call them as medial occipitotemporal gyrus and the lateral occipitotemporal gyrus. So these are the spaces which is present on this particular orbital surface and the tentorial surface. Now from this particular area, we are going from this area which is placed in the central part of this inferior view of this base of the brain. So in the inferior view of the base of the brain, this region where I am rolling this region which is lying here, we call this as a depressed point or a kind of socket area. We call this as an interpeduncular fossa. So this particular interpeduncular fossa, which is a space which is present in the inferior surface of the brain, which is present around here, which is present around this region. Now it has a boundary which you have to know. Now how far you are going to say that this is an area about interpedunculaire fossa. So you have to know the boundary anteriorly, posteriorly, laterally, medially, and what are the contents that is present to it. So this particular interpedunculaire fossa is limited anteriorly by this optic chiasm, which is the crisscross of the optic nerve, and posteriorly by this particular midbrain, which you have this particular region is pons here. So anteriorly we have this particular optic chiasm, and on the posteriorly we have the pons. Then we have this anterolaterally, which is present on here, which is the optic tract, right and left, and on the back side, this tissue, we call them as peduncle, which is known as the cerebellar peduncle. So which is going from this pons to this particular cerebellum, we call them as middle cerebellar peduncle. So which is limited posterolaterally by this peduncle, also known as cerebral crotch. So in between this region, we have this particular area of the neural tissue. We call them as interpedunculaire fossa. So if you go deep, if you just like put a probe here and pass upside, you are landing up into the brain space, which is related here, which is known as third ventricle. So third ventricle is lying on the top side or above, which is lying on this region. And along with that, we have the subarachnoid tissues present on that particular region. Now, what are the structures that is present in this particular interpedunculaire fossa? The structure which is present in the interpedunculaire fossa, front to back, we have the optic chiasm. Then we have a tissue of the gray matter which is present in here. We call them as tuber cinerarium. From the tuber cinerarium, we have a tissue which is hanging down, which is known as infundibulum. Through the infundibulum, the pituitary is held to this particular sella turcica chamber. Now next to that, we have these two bulbs over here. We call them as mammillary bodies. Now on the posterior side of the mammillary bodies, we have a space which is little bit have pores in it. We call them as perforated substance. So this perforated substance present on the posterior aspect, we call them as posterior perforated substance. Now next to here, we have a nerve emerging in it, which is third cranial nerve, which is emerging out of it. So you have a nerve tissue which is present, which is not visible in here, which is ripped off basically. When you have this wholesome picture of this brainstem, we'll be seeing that particular nerve, oculomotor nerve or third cranial nerve, which is exiting through it. And we have a vascular structure present in this space, which is the circle of Willis. Now many a times the circle of Willis, we see that coming as exam question, right? Now there might be some deviations of the question maybe popping up. Rather than asking about the circle of Willis directly, they might ask you about the boundaries or the place where the circle of Willis is placed, which is the interpedunculaire fossa. You have to know about the boundaries of them and the rest of the content. So this particular thing is a kind of short note which could be surfacing in your exam. We must prepare this. So boundary, content, and this relationship of this particular space which is lying between this particular brainstem and this particular optic chiasm on the anterior side. Interpedunculaire fossa, which is a space which is lying between the two cerebral hemisphere and the central part of it. Now from the interpedunculaire fossa, we are going to talk about another clinical problem or clinical aspect. We call them as optic chiasm. And again, this is a very important short note. For the physiology, of course, we learned about it. We have this particular optic chiasm coming up in every alternate year. Here also we see this particular nerve is coming. So if you are going to define this optic chiasm, which is a flattened kind of optic nerve crisscrossing over here, which fibers are crossing, nasal fibers, temporal fibers are not crossing over here and placed in this particular region, which is known as interpedunculaire fossa. Now you have to know about this particular anterior relationship of this particular optic chiasm, which is running over here. We have a blood vessel running over here, right to left. We call them as anterior communicating artery of the circle of Willis, which is present to it. And above here, we have this particular same third ventricle. So this particular optic chiasm is basically making the boundaries of interpedunculaire fossa. Deep to here, we have the third ventricle present to it. Now, the important feature about here, next to this optic chiasm, we have a space where I am placing this particular marker over here, this region and this region. Just like this particular posterior perforated substance, this particular region where you have these particular dots like this, we have also perforation there. So this perforation which is present on here, which is present to the anterior aspect of the interpedunculair fossa or anterolateral aspect, we call this as anterior perforated substance. Now what perforates through them? Blood vessels runs through it. The blood vessels which is coming from the cerebral artery runs through this substance of the brain, perforating through them, and goes to the deeper structures of the lateral ventricle, thalamus, hypothalamus, so on, and goes to this. The branch of the arteries which pierces through the perforated substance, we call them as striate branch. So striate branch of these cerebral arteries runs through this particular perforated substances, anterior and this posterior perforated substance. So you have to know what do you mean by the perforated substance, why they are called perforated substances, and what exactly pierces through them, and where exactly they are placed, anteriorly and posteriorly. So the anterior perforated substance pierced by the arteries, which is anterior cerebral arteries or branch of anterior cerebral arteries. The posterior perforated substance is pierced by the branches of the posterior cerebral arteries. And the branch which are piercing through, we have a special name to it. We call them as striate branch of the cerebral arteries, which are going through them. So this optic chiasm, the clinical importance to this particular optic chiasm again, which is related to the hypothalamus or stalk of pituitary, which is enlarging, pressing on these crisscross fibers, which is putting over here bitemporal hemianopia, blah blah blah, and the visual field defect. We all have to draw about it. So whenever you have this particular optic chiasm, you have to draw the picture, draw this particular region and this particular like clinical anatomy related to it. Now we forget about one thing to mention over here, the blood supply of the optic chiasm, which is coming from the anterior communicating branch of the circle of Willis, and as well as the branches coming from the anterior cerebral arteries, which are the branches, blood supply to this particular optic chiasm, which is receiving the blood through it. Now sometimes we lose these particular branches which is supplying to this particular optic chiasm and eventually leading to the damage or necrosis of these particular fibers which is coming through it. So this is about optic chiasm. So coming from the optic chiasm, we are going to talk about the much talked and hype talked about, which is known as circle of Willis, which is a network of these arterial connections or anastomosis, which is present in the space. We call them as interpeduncular fossa, which is housing this particular thing. Now how this circle of Willis is present and how this circle of Willis is formed, we have to talk about and we have to see. So we have to know about this particular schematic pictures, how to draw them. We have the arteries which is coming over here, which is the middle cerebral artery, anterior cerebral artery and a posterior cerebral artery. Each of them has a contributory role in formations of the circle of Willis. So taking this back side first, the posterior cerebral arteries, right side and left side, they gives a branch coming from this basilar artery which is splitting into this particular posterior cerebral artery, which is a terminal branch. So this posterior cerebral artery is communicating with this particular internal carotid artery through a series of artery, right side and left side. We call them as posterior communicating arteries, which is making the circle of Willis on the back side. Now this internal carotid artery sends a branch over here which is going like here. We call them as anterior cerebral artery. So anterior cerebral artery and this middle cerebral artery, they are branches of these internal carotid arteries. So the internal carotid artery sending this branch anteriorly is anterior cerebral artery, which is making this anterior half of these circle of Willis. Now then, between this anterior cerebral artery, we have a communicating or bridging artery between them, right to left. We call them as anterior communicating arteries. So this posterior communicating arteries is 2 over here compared to this anterior communicating artery 1, which is present on the anterior side. So whenever you're drawing this particular picture, might be looking easy, keeping it just like a tentacles on these different areas and drawing and joining them. But often during examination, while you're sitting there and drawing it, if you haven't practiced it enough, we are finding difficulties in drawing it appropriately and labeling it appropriately. So again, you are losing marks. You're knowing something, half known topic is again, it's equivalent to not knowing, because you cannot treat your patient halfly. That I will treat your right half of the illness and left half of the illness will be left along, and again you will be losing the patient eventually. So this particular circle of Willis, the positions of the circle of Willis, the formations of the circle of Willis, where it is forming, what are the contributory branch, what the location of it, you have to know about. Now, what is the significance of having this? So, if sometimes we have a stoppage or a sluggish flow or have a poor flow on the blood circulation between this particular artery, the other arteries which is linked to it kind of compensate to some extent. So, for example, if you have this particular trouble or blockage of this anterior cerebral artery of the right side, now having this anastomosis, the opposite side of this particular anterior cerebral artery might compensate back to this particular region which is supplied through this particular right side anterior cerebral arteries, and likewise to this particular posterior cerebral artery and the posterior communicating arteries. So if you have a blockage in one half or any of them, the other half might be able to compensate that depending on the limits of this compensation where it is there. So this is the significance of having this. Now, other significance of this is a clinical thing. So, if you have this particular problem about this particular injuries or diseases related to it, sometimes we see that there are dilatations of this particular arterial system takes place. So, that dilatations is maybe just like looks like a sac, maybe looks like a bulb. We call them as saccular dilatations or kind of like a bulbar dilatations of this particular cycle of Willis content. Now, this particular dilatations of this particular blood vessel leads to the weakening of these blood vessels. So, if you are having a person who has this particular problem, we call them as dilatations of this blood vessel, which is known as aneurysm. We call this aneurysm or involving this particular circle of Willis as a Berry's aneurysm. Now, if you have an individual who has a weakened blood vessel as a Berry's aneurysm and they have a high blood pressure, 200 by 100, what is the normal blood pressure? 110 by 70, 120 by 80, whatever it is. Now, if it is shooting high, uncontrolled hypertension, 200, 220, it might rupture this particular Berry's aneurysm, can leak the blood there and lead to this particular leakage of the blood, go into the space. We call them as subarachnoid space. So, subarachnoid hemorrhage could be a common complications which is arising out of this rupture of this particular aneurysm. We call them as ruptured Berry aneurysm. There are several points are there within this anterior Berry circle of Willis and a posterior segment of the circle of Willis which are prone to have a common site of formations of these aneurysm, which is known as Berry's aneurysm. So we do not have to memorize the common sites. We do not have to memorize them at least at this point. But we should be knowing there are some points, not entire length of this particular circle of Willis is prone to have these saccular dilatations or also known as this particular Berry aneurysm. By the way, Berry aneurysm is no more used nowadays, but because of these books are following, nowadays we call them as saccular aneurysms. So the saccular aneurysm is synonymous with the Berry's aneurysm. So these things about this circle of Willis clinically we have to mention as a content whenever you are going to address that clinically or as well as in a theoretical exam. Now moving from there, we are going to talk about minor details about the things which you have talked about. This particular region we call them as interpedunculaire fossa content. We mentioned about that content which is having a gray matter tissues which is known as tuber cinerarium or cinerium, which is a kind of next to this particular optic chiasm between this particular green shadows. The green shadows are mammillary bodies. So these mammillary bodies is related to the olfactions for our perception of the smell. So between this optic chiasm and these particular mammillary bodies, we have a strip of the tissues which is lying between them. So this region is layered by a gray matter tissue. So this gray matter tissue, we call them as tuberous cinerarium, which is forming a stalk of this particular pituitary. We call them as median eminence. So this median eminence, which is eventually getting to the stalk of the pituitary, linked to this, we call this as a tuberous cinerarium. The mammillary body, as I mentioned, which is colored over here green, which looks like a tiny dot, P-shaped. This is a white matter tissue, which is present in here, related to the olfaction or the smell perception of the individual, which is present as a content. So that's also, whenever you're seeing that, you have to know. Now, next to that, a tiny space present next to or lateral to the optic chiasm. We have this optic tracts, optic chiasm, and next to that, we have this space where we have this perforate substance is there. So this particular entire space we call them as vallicula. Just like tongue has vallicula, we have this particular vallicula which is looks like a valley. Now this particular space which is vallicula has a boundary which is bounded anteriorly, posteriorly and as well as medially and laterally. Posteriorly it is limited by this uncus, anteriorly which is by this olfactory bulb which is getting over here, and this particular medially by this optic tract and optic chiasm which is present, and laterally by this uncus which is present in this particular lateral region as well, so or also known as the lateral stem of the lateral sulcus. So this region where you see this particular content, where I am rolling this, we call them as vallicula. Now what this vallicula is significant of? This vallicula holds two substances. One is the perforate substance, as I mentioned. This perforate substance is present over here, we call them as anterior perforate substance. Now within this anterior perforate substance, we have a blood vessel present in here. We have this artery which is coming over here, we call them as internal carotid artery. So the internal carotid artery present into this particular place, splitting into the anterior cerebral and middle cerebral artery. Middle cerebral artery, once splitting into, disappears into the stem of the lateral sulcus. The anterior cerebral artery runs this anterior course, joins and makes this particular circle of Willis anterior communicating branch. So this particular space we call them as vallicula, which is lying lateral to the optic chiasm, and it is a space which has been occupied by this internal carotid artery, ICA, and anterior perforate substance. And as again, anterior perforate substance presents with some kind of like a blood vessel which is piercing through, we call them a striate branch of this anterior cerebral arteries. Now from here, talking about the substances, as I mentioned, anterior perforate substance, posterior perforate substance. Anteriorly placed on the vallicula, we just mentioned about it. Posteriorly, behind this particular bulge over here, we call them as mammillary body. And this is the brainstem, this pons which you are seeing here, midbrain pons. In between them, we have this centrally placed substance. We call them as posterior perforate substance. Posterior perforate substance are pierced by the striate branch of the posterior cerebral arteries. So we have two spaces there. They are basically the point through which deep penetrating branch which is going to supply the medial half of this particular brain, the region we call them as, or going to see next to it, which is lateral ventricle, which is present on here, the third ventricle, which is present in here, hypothalamus, thalamus. They are receiving the blood through this striate branch. If you have a rupture of this particular striate branches, if you have a thrombosis to the striate branches, the effects are more deadlier compared to this particular like a blood rupture or blood blockage on this main artery, which is MCA territory or anterior cerebral artery territory or posterior cerebral artery territory, because the striate branches goes penetrating the tissues deeply. We cannot do or any surgical interventions if you have the striate branches ruptured or thrombosed. So these are the posterior perforate substance. These are the things about this particular base of the brain that is required for our understanding here. Next we are going to talk about this particular brainstem. We also known about this particular space, midbrain, pons and medulla. We just discussed about the medulla in the previous session, which is the lowest part. Between there we have this particular, then we have this particular brainstem continued as a spinal cord. Beyond this foramen magnum, posteriorly we have this particular region, we call them a cerebellum. So in between them we have this particular tissue, this particular midbrain, brainstem, this particular medulla oblongata. Ventrally and dorsally have some projections. We call them as pyramids, and these and the olives and the gracile and cuneate tubercles, which is present on the dorsal side and the ventral side respectively. And we have this particular cross section. We already have drawn about it. So I am not going to talk about the brainstem out here because we have to discuss it in a separate class. Neither I am going to talk about the cerebellum. We have a separate class on it. Now directly I am switching to this particular area. Next please. To this particular cranial nerve exit point. So this is what we are talking about. This is the brain which is taken out. Rift through here we do not have any nerves. Now this is everything which is base of the brain. Whenever you are removing the brain, ideally in a fresh brain specimen, this particular structures or the cranial nerves, we must be able to see, or we should be seeing many of them. So if you just like identify them, looking over here, this is the olfactory nerve, cranial nerve number 1. Right and left. Then this is optic nerve making the chiasm and making the tracks next to it. Next to that, we have this particular nerve. This nerve we call them as content of the interpeduncular fossa, which is a third cranial nerve, oculomotor, which is present in here. So this region, again, once again, between the crotch laterally, we have this midline space. We call them as interpeduncular fossa. That's what we just talked about. Next to this particular interpeduncular fossa, if you move laterally, you find a skinny nerve over here, which is nerve number 4, trochlear nerve, which is present in here. Number 4, then you are going down over here, which is on the side of the pons over here, which is cranial nerve number 5. So the trigeminal, which is present on the 5. Then going down in the midline, pontomedullary junction, in the front side, we have this nerve number 6, which is anchored to it. Next, on the pontomedullary junction, if you're rolling on the lateral side, also known as angle of the pontomedullary side junction, or also known as lateral angles, we have 7 and 8 exiting through here. Then we have this particular midline cleft, we call them as sulcus, anteromedial sulcus. Then this is the brainstem part, we call them as medulla oblongata. This is the bulge, we call them as pyramids. Next to that, we have the olives. Now we have to find these olives, medial to the olive, lateral to the olive. Medial to the olive, we have this nerve exiting here, cranial nerve number 12. Then lateral to the olive, 1, 2, 3, 9, 10, and this down over here is the spinal accessory, 9, 10, and 11. So these particular orientations of the pictures, which are the exit point of the cranial nerve, we call them a soft exit point on the brain tissues. That also you have to know. And similarly, within this base of the skull, through the foraminers, when they are exiting, those are the things we have to know. This can be given as an exam content, exam picture, and mostly in a practical. And again, at the base of the skull, again the dry bone specimen, which could be given as an exam content as well. Now, this is the content, whatever we have learned so far. Again, to summarize, we'll be knowing this particular base of the brain, also known as inferior surface of the brain. We have to know these things. We are seeing this cerebrum, orbital surface, tentorial surface. We have the gyrus recti and the orbital region. Then we have this particular tentorial surface, collateral sulcus, and this occipitotemporal sulcus, which is present on the front side to back side, anteroposteriorly, splitting these areas into 3 different areas. If you forget about those areas, doesn't matter. Just ignore. Just know these particular surfaces, whatever you are seeing them. Then you have to know the interpeduncular fossa, the boundary of the interpeduncular fossa, anterior, posterior, laterally, how they are there, and the content of them, and what are the things that lying deep to or above that region. Circle of Willis, which is a prominent content, which you have to know clinically very well. Optic chiasm, you have to know them very well. You have to know the clinical aspects and as well as the theoretical gross anatomy of it. And then you have to know about the perforate substance. The perforate substance, again, whenever the base of the brain is given to identify, they ask about this particular base of the brain region, perforate substance. And whenever you are given the perforate substance, anterior perforate substance is a very important region. The examiner points you about this anterior perforate substance and asks you about what the space is called. We forget about that space where this anterior perforate is located. We call them as vallicula. So we can remember that particular name, vallicula. You utter the word, it sails through. Besides this anterior perforate substance, you have to know what pierces through these particular tiny holes, blood vessels. If you can remember the name of the branches which is piercing through, we call them a striate branch of the arteries, anterior or posterior cerebral arteries, anterior and posterior perforate substance respectively. And internal carotid artery, of course, placed in the vallicula, which is there. And this soft exit point of the cranial nerves, how they are placed in terms of the brainstem and the inferior surface of the brain, that matters to us. So, these are the things that you are going to prepare for your examinations. Alright, that's all. Doubts, queries? Hope not. Alright, good to go.